Hello and welcome to Desera Clinical Education's Oncology Podcast. I'm your host, Kendall Schick. Today's episode features Ibrahim Aldoss, MD, from City of Hope National Medical Center in Duarte, California, and Bijal Shah, MD-MS, from the Moffitt Cancer Center in Tampa, Florida. Today they'll be discussing the future treatment of acute lymphoblastic leukemia and key clinical trials. This episode is part of a larger educational program titled Shaping the Future of ALL, Clinical Advances in Immune Engager Therapies and Patient-Centered Care. For more information on Drs. Aldoss and Shah, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about immune engagers and ALL.
Hi, my name is Dr. Bijal Shah from the Moffitt Cancer Center. I'm joined by my very dear colleague, Dr. Ibrahim Aldoss from the City of Hope. And we're here to talk about ALL, acute lymphoblastic leukemia. Ibrahim, just as a kind of a starting point, where are we in 2026? I mean, there's been a lot of changes, I think.
Thank you, Bijal. I mean, we have made significant progress in ALL, especially in B-cell acute lymphoblastic leukemia, where we have seen recent advances in frontline therapy. And this is a result of kind of optimizing frontline chemotherapy backbone, the integration of immune therapy early on, improve risk stratification, the integration, the more precise identification of high-risk patients based on the MRD response and the molecular profile of ALL. And these actually advances have contributed to better initial disease control. Now, progress in relapsed refractory B-cell has been also particularly notable in recent, I would say, decade, in the last 12, 15 years, with several antibody-based and cellular immune therapies approved in recent years. These include intuzumab, which is an anti-CD22 antibody-drug conjugate. We have blinatumab, which is a bispecific T-cell engager. And more recently, we have three actually approved CD19-targeted CAR T-cell therapy approved for patients with relapsed refractory B-cell ALL. This is T-cell, Prep-cell, and obe-cel as well. Now, despite these advances, I would say, substantial challenges persist. While real-world data and clinical trials demonstrate significant immune therapy efficacy in relapsed refractory B-cell ALL, many patients, unfortunately, remain at risk for relapse, although the response early on is high. But beside, the efficacy part, there are some treatment-related toxicities we should take into account, including cytokine release syndrome, ICANS, that we see with CD19 target immune therapy. But also there are some challenges in how to administer these immune therapies. You have blinatumab, it requires 28 days continuous infusion. You have CAR T-cell therapy that require T-cells collection. Then it takes 4 weeks to manufacture these CAR T-cells, as most of the, I would say all the approved CAR T-cell therapy at this time are autologous CAR T-cell therapy. So with that, there is critical unmet need for immune therapies, that we need a safer immune therapy that produce more durable remissions and potentially cure, as well as more accessible and easy to administer.
That was incredible. You just laid out, I think, in really extraordinary, this incredibly abbreviated but comprehensive summary. So I'm going to dig in a little bit and maybe provide commentary, if nothing else. I think in relapsed refractory ALL, it's wild, right? When we started, we were talking about an expected survival, in first relapse now, right? Long-term survival around 5 to 10% for patients, with B-ALL. This is coming off of the hyper-CVAD data. This was coming off of the ECOG 2993 data, and we're now in a position where we can say with some degree of certainty that we'll probably cure somewhere between 30 and 50% of patients who relapse after, their initial, course of chemotherapy. And wow, that is a sea change. That's a really big deal. And so I think that immunotherapy has played an enormous role in helping us to get there. And I think it also informs how we think about the frontline setting a little bit. But, when we talk about relapsed refractory therapy, integrating blinatumab for MRD ALL, first got us to that 50% benchmark in terms of curability, still dependent on a transplant. And I think that that's something we still have to make sure we think about in 2026. We're not able to really say that we're talking about transplant-free therapy yet, but I think a major step forward. We talk about CAR T-cell immunotherapy. Same thing. We've got the 5-year data now with Brexucell. We've got emerging data with Obe-cel. But, again, kind of hitting that 50% plateau, despite the fact that these patients are heavily pretreated. So it really begs the question, or begged the question, since we're really talking about, past tense now, why can't we bring these therapies forward? We've now got blinatumomab incorporated into frontline therapy. We've got, not just for Philadelphia negative patients, but also pH positive, and seeing extraordinary outcomes, with ponatinib and blinatumomab, what we used to call high risk ALL, which was Philadelphia positive. Now we can really relegate that to standard risk for the most part. And, it's just been incredible to watch. I'm also enamored by some of the data you're generating with frontline CAR T, but you hit the nail on the head, right? When you were talking about toxicity, and I do consider administration of the drug as a component of toxicity. I know it's a strange way to think about it, but if you got to hospitalize a patient for a month, if you have to, if the delivery is really cumbersome, right? If patients got to drive back and forth, and it creates a conundrum, right? It creates this challenge of delivery. And I think that that's something that we really got to make sure that we think hard about. And so when we talk about bringing novel bispecific antibodies into the frontline setting, whether that's acute blinatumomab, whether that's Merck 1045 or survodimig, I think what the real promise here is we may be able to blend this with therapy and achieve extraordinary outcomes. What's your take on kind of maybe focusing on some of the bispecifics, how some of these are delivered, right? Because we've got now a few different options. We've got intravenous blinatumomab, subcu blinatumomab, survodimig, the Merck 1045. What's your take on the administration of these?
No, I completely agree with Bijal. I mean, especially as we're moving this actually agent to frontline setting, I mean, I agree. I mean, the convenience for the patient is very, very important. And this is where the field should move. We have effective therapy in the relapsed refractory setting, is how to actually bring it earlier, especially in adults who are actually chemotherapy. They tend to have disease that is more chemorefractory, and they tend to develop more toxicity to chemotherapy. So replacing chemotherapy, especially these long regimens, with more effective, less toxic immune therapy in the early setting, I think this is where the field should move, and we can shorten the duration of treatment of ALL. So as we're giving it actually to more patients, I mean, it makes sense we have to select agents that are actually more easy to administer to the patient. Continuous infusion blinatumomab, it can be convenient for some patients, but many patients, they cannot handle the fact that they have to be on continuous IV cancer therapy for 28 days. Subcu blinatumomab, I mean, seems to be very active, but it requires frequent visit to the clinic, and not everybody lives close to the actually treatment center, and that actually add more burden to the patient and the family as well. So I agree. I mean, I think coming up with more convenient immune therapy, it's an important thing, and it actually decreases the burden and the toxicity on the patient. And we're very excited with agent like MK1045, where it's given weekly. We have survodimig that can be given every other week, and eventually can actually move to the monthly schedule. And I mean, it's a great experience for the patient, less kind of burden on them and their family as well. So, I mean, with that, Bijal, I mean, let me ask you about the emerging bispecific and trispecific antibody strategies in ALL. Of course, now they are in the relapsed refractory setting, but as you mentioned, I mean, the hope how we can bring them early on for our patient with newly diagnosed ALL.
Yeah, I mean, I think I loved what you said about replacing elements of the chemotherapy backbone. The only thing that's really moved the needle has been the incorporation of immunotherapy into this setting. And so when we talk about replacing the chemo backbone, it's not a matter of if, it's overdue. We got to find a way to do this, and we got to find a way to do it right. That's part of the promise. I think the other part is, you alluded to it, 3 years of therapy. That's what we're talking about for the average adult coming in with newly diagnosed ALL. That is not an easy go if you're a young adult trying to go to school or hold your first job. That's certainly not an easy go for someone who's mid-career trying to get promoted. And if you're retired, trying to enjoy that retirement, it doesn't fit with anything that we would call normal life, and managing the toxicities and cytopenias in those parts. And so we really have a responsibility to improve survival, but also the practical delivery of therapy for patients with ALL, and I think immunotherapy is the path forward. You asked a second question, which was how do we think about some of these novel agents in terms of integrating them onto our chemo backbones, and I think it is something that I also spend a lot of time trying to dissect. And what do I mean by that? Think about it as something that is given commensurate with therapy, and an example of that would be giving blinatumomab and inotuzumab together. Or is it something that we need to think about sequentially, where we give something and then we want to avoid any T cell toxicity, and so we would just give the bispecific next? And that's the latter has been the method that we've been employing, but we're really talking about very, very potent therapies that we're now able to space out. You mentioned survivorumab maybe once a month. I mean, that's huge. Your opportunity now to say, okay, I'm going to give my once a month therapy. I feel comfortable integrating inotuzumab or some other thing here onto this, because look, we don't have to worry as much about the toxicity with this approach, because we're really able to space out our dosing, and it changes a little bit of the dynamic of what we're doing, allows us to compress therapy with, again, therapeutic benefit, without losing folks along the way. I think it's early to talk about the trispecific. It's interesting. I think that I think it's a cool concept, but it's going to be hard to really show that it's profoundly more active than the bispecifics that we currently have in the mix. And what do I mean by that? Ibrahim, you're front and center on the survivorumab data. I mean, we're talking about 70, 80 percentile complete remission rates. I mean, many of these are MRD negative. I mean, this is massive. I mean, I'll pause there and let you fill in the details, but I've been very impressed with what we've seen so far from again these novel bispecifics.
Yeah, no, I agree. I mean, I mean, the bar is kind of higher and higher to compete with. And kind of comment about the survivorumab. I mean, we're very actually excited and impressed with the data. I mean, in the SARA study, which is a phase 1/2 dose escalation, optimization, and expansion trial that tested survivorumab as single agent, which is a CD19 T-cell engager that is unique, where it has a lower affinity CD3 that actually release less cytokines, and therefore we're hoping with less CRS and toxicity, and this will allow actually for higher exposure and increasing the dose. But at the same time, it also has a long half-life that can be between 8 and 12 days, and this is what's supporting the administration every 2 to 4 weeks. And what we have seen in the SARA study, I mean, very encouraging data early on, even with the lower dose level, we have seen responses in the 40%, including patients who failed prior blinatumomab and CAR T-cell therapy. And as we escalating the dose, we're not seeing actually dose-dependent increased toxicities, but we're seeing actually dose-dependent improved response, where the response rate with dose level 3 was as high as 82%. And these responses, as you mentioned, I mean, the majority are the MRD negative, patients who failed blinatumomab, CAR T-cells, and as well as some of them are triple exposure, including inotuzumab as well. And what's unique with responses, that's unlike what we see with blinatumomab, where we see actually less response if the patient has high disease burden, if they have extramedullary disease. We have in patient with high disease burden, patient with extramedullary disease, that they respond to single agent survivorumab. So this is where all the excitement of survivorumab coming. The high MRD response rate, even in heavily pretreated patient, as well as actually the safety profile for the drug. I mean, we only have seen grade 1 and 2 CRS and ICANS, with one grade 3 CRS and one grade 3 ICANS. So this is why we have all this excitement, and we think this is maybe actually a more powerful drug compared to blinatumomab. It's maybe as comparable as to CAR T-cell therapy, but it is available off the shelf. You don't need to make the CAR T-cells, the drug, to give it later after 4 weeks. And Bijal, I mean, some of those relapse ALL can be very proliferative, very difficult to maintain, kind of some control to be able to collect the T cells, then actually give the CAR T cells after 4 weeks. Many times we lose these patients while we're trying to make the CAR T cells. So this is why we're very excited. And the same thing we're seeing actually with other bispecifics, including the CN-201 drug, which is similar to survaltimig, but it is given once a week. And again, data still early, maybe patient not as heavily as pre-treated as survaltimig, but the data also very encouraging. And it has the same structural concept, longer half-life, lower affinity, where you see actually less CRS. We haven't seen, at least the investigator, they haven't seen any ICANS in their study, but the study is still early on, still accruing patient as well. So, I mean, with the high response rate, where we feel that blinatumomab has really actually moved the needle in frontline therapy for ALL, if we have a more powerful drug than blinatumomab, more convenient to give, are we able to actually improve furthermore? And which make it also harder to kind of look at trispecific. How is this will improve outcomes compared to some successful drug like survatimab, so like the CN-201 drug as well. We have all these CD19 target therapy. I mean, it's getting very crowded in relapsed refractory setting. And of course, survatimab, the MK-1045. Initially, I mean, the goal is to get them approved in the relapsed refractory setting, with eventually the plan to bring them early on. With all these drugs, the blinatumomab, the 3 CD19 CAR T-cell therapy, the emerging CD19 bispecific, where do you see this emerging CD19 bispecific in the relapsed refractory setting? I mean, let's say that survatimig tomorrow gets approved. How to select for someone who's CAR naive between survatimig and CAR T-cell therapy for relapsed patients?
I love the question. And I think it is really, really important to help, navigate that space. Number one, I see these therapies as complementary. I think that, and again, the work that you've done, Ibrahim, contributes to this data set, right? Giving blinatumomab in your trial prior to CAR T-cell therapy as a consolidation for older adults worked. Even though the patients were MRD negative, it worked. And it builds on this idea that we may be getting some, for lack of a better term, tumor vaccination with our bispecifics. And so you have your patient with bad ALL, you want to give them the bispecific, and maybe you have a go, no-go decision, right? They're doing well, they achieve early MRD negativity, which, by the way, most of the patients on the survatimig trial, were MRD negative after the first cycle. But you see something that says, okay, I'm concerned maybe you're not MRD negative at 10 to the minus 6. I've essentially done my tumor vaccination, right? I've given my novel bispecific, and now I'm going to consolidate with a CAR and kind of let the immune system take over. And it again allows us to punctuate the therapy. Still requires some organization in terms of keeping the patient there for a month. I'm not going to say that CAR T is a button you can push, but perhaps allows us to think about these novel therapies synergistically. And that's why I was saying, right, these longer half-lives, the ability to space out therapy, really drive the T cells, to behave in a way that's complementary to what we're trying to achieve with CAR T may allow us to get over that hump. But I have a feeling what you were really asking me was not how I'm going to combine BiTEs and CARs. I have a feeling what you were asking me is, what does it mean for CD19 loss and for those patients who are otherwise CD19 refractory, right? Because we can't really talk about relapsed refractory B-ALL without talking about prior CD19 exposure. Now that blinatumomab is really recommended frontline for everyone. And that's a hard one. And I really try to go back to the molecular biology as much as I can. You'd mentioned when you introduced kind of where we are in 2026, this idea of being able to understand high-risk genotypes, not just MRD. I think about the P53s and what that might mean in terms of novel targeting approaches for those, patient subgroups. We're still a long way off. I mean, we saw the eprinetapops data, in AML, which almost got us there. I mean, there's sort of a lot of almost in P53 AML, but I think lots of opportunity to try and figure out how we can continue to develop that strategy. Again, a molecular strategy in ALL that even perhaps one day we could combine with immunotherapies, we've got the menin inhibitors now making really, considerable progress in the MLL rearranged space. And I could go on and on, but I would say a testament to this sort of therapeutic idea is what we've done with bispecifics and TKIs in the context of pH positive disease, what we're actively doing and learning with now CAR T and TKIs. And so I think where I hope we land, right, in the next 5 years, very low dose chemotherapy to prepare someone to receive a bispecific, and maybe we won't even need it. Maybe the again, where we're at with bispecifics is going to be so active that we may not even need anything more than a little bit of steroid before integrating a bispecific without having to worry about toxicity. Thinking about what that means in terms of immune stimulation, maybe delivering that with some kind of a TKI component, and then following up with a CAR. And then for those patients that relapse, despite our CD19-directed strategies, thinking about what we can do with other immune-directed approaches, maybe not targeting CD19, but with some of these molecular tools, or maybe even building those again into that bipartite approach. So a long-winded way of saying the more tools we have, the better off we are.
I agree with you. I mean, everything you mentioned, I mean, I think this is where the field is moving. Is the only thing, I mean, we live in kind of time where finance, insurance may not approve you give like 2, 3 novel drugs like sequentially. You have to fail one before you move to the other one. At least when we talk about the relapse refractory setting. So the question I have, Bijal, someone with relapse leukemia, I mean, like when do you decide that I want to give CAR T-cell therapy? Again, now everybody actually gonna have some exposure to blinatumab in frontline therapy. So I mean, it will be very difficult to have a patient didn't have blinatumab exposure before. So I think the bigger question is between these emerging CD19 bispecific antibodies and between CD19 CAR T-cell therapy. And as we made actually progress in CD19 bispecific, we're making progress even in CD19 CAR T-cell therapy. I mean, with the recent approval of obe-cel, I mean, where, previous CAR T-cells used to have a lot of toxicity, although manageable. Obviously, you have less grade 3 ICANS compared to the other ones, which made it actually easier to kind of offer it to frail, for older patient, even for younger patient. I mean, many practices, they move completely from kind of older CAR to more recent, to more newer CAR for that reason. But now you have the CAR, you have the bispecific, and it's also an active bispecific. Where do you see that you would favor maybe bispecific over CAR versus CAR over bispecific in relapsed disease?
Yeah, I mean, and I was kind of hinting that a little bit. So I think on the good news is most of us are going to be following our patients fairly closely, right? So they're receiving chemotherapy with blinatumab now is kind of the standard. And, I really put a lot of thought into how to reframe our NCCN guidelines to address MRD. And we created this concept of persistent or rising MRD as a criteria to move directly to salvage approaches. So, starting at that very early stage of saying, you know what, I'm 2 or 3 cycles in, maybe I've already integrated my blinatumab and I haven't cleared MRD. I think at that point in time, you have the warning bells are sounding. You need to really think hard about what you're going to do and how you're going to move, and being able to move again from an insurance standpoint or a coverage standpoint, being able to move now to novel approaches is now protected, right? It's now built into the guidelines so that it's accessible. So I think that's the first piece. And now if I'm talking about integration in the MRD setting, you got a little bit of time, right? You got time to collect, you got time to administer, you got time to do things. And I think that there's really tremendous opportunity for integration of CAR, whether that's Brexucel, whether that's obe-cel. It's funny, we do spend a lot of time talking about toxicity with these 2 different CARs, but to your point, it's gotten to the point where even with grade 3 toxicity, we're still talking about, an average of 10 to 12 days of hospital stay, right? It's gotten to be very, very easy to deliver both products. And now the question that I think we're all struggling with is, okay, which one is the better one to give? Which one is the easier one to give? Which one's the more effective one to give? And I think that those are the questions that are going to continue to track us, and may again have more to do with reimbursement based on time of hospitalization if hospitalization is required. So I think the CAR for MRD, early MRD is probably where I'm going. But we have to acknowledge that somewhere between 5 and 10% of ALL will be refractory, or those patients will simply be unfit. Right now, we're limited, right? The trials are third line plus, and I think it's going to take us a little bit of time to move some of these novel bispecifics forward. But, trying to think about how we move novel bispecifics into that second line setting or even the front line setting, if you want to think about it that way, maybe someone's MRD negative, but they're just unfit for therapy. How do we integrate this so that we can improve outcomes? And again, use an MRD adapted approach. If they're failing to clear it early, we've got our CAR as a backup. We're still going to be stuck with CD19 negative relapses. And I think that's always going to be the challenge when we talk about, again, these particular genotypes. We're going to find out that ALL really emerges, well before, that, LMPP step in hematopoiesis, right? Lymphocyte, monocyte, progenitor population. We're going to find out that we're probably seeing some of these ALLs emerge from stem cells that have a myeloid component to them. We're already seeing that in DUX4 rearranged ALL. We're seeing that in some of the P53s, and I could go on and on, but I think if we don't acknowledge that, if we continue to try to operate agnostic of the genomic sort of counterpart, then we're also doing ourselves a disservice. So we have to figure out how to integrate those pieces when we talk about, our approaches. And, to your point, maybe that is the place where you say, okay, I need to think about antigens beyond the classical B-cell antigens, CD19, CD22, and so on. But I want to ask you a hard question because you've been asking me hard ones. So I want to ask you, what is the role for allogeneic transplant in 2026?
Yeah, I think for transplant naive adults who relapse, we still recommend transplant. Now, when I have an adults who relapse and they're not fit for transplant or they don't have a donor, which is unusual nowadays, but at least you have some adults who relapse, they're transplant naive due to psychosocial issues, maybe frailty, some chronic disease, they're not eligible for transplant. I tend to go with the salvage therapy that provide actually the most durable remissions. And as of now, what we know, we think CAR T-cell therapy is the way to go to kind of try to cure these patients without subsequent transplant consolidation. But I think the field is evolving. We're trying to see who really can be cured without transplant consolidation. We have seen some data suggest maybe patients who relapse after transplant and they receive CAR T-cell therapy, they could have durable remission and potentially cure without transplant. We have seen patients with Ph positive ALL who receive TKI maintenance afterward. They have durable remission. Are they cured? I don't think we know. It's not like someone who had transplant, then you try to kind of stimulate the GBL effect to take over and prevent relapse. For someone who's transplant naive, the question TKI and Ph positive ALL, will it just kind of delay the relapse or truly actually cure the patient? So, I think there's still significant role for transplant naive. For someone who relapse after transplant, typically second transplant is difficult to do. Many of us will try to optimize actually the setting before we give the salvage therapy to improve the chances of cure, like try to reduce the disease before lymphodepletion so we can have a better chance with CAR T-cell therapy in curing the patient, or at least extend the durability of remission. Now, with these emerging bispecific antibodies, the truth we don't know. Data is still early. I have patients who has been on the sorvatimig more than a year and a half, and she's still in remission, and I didn't do transplant because she's frail. Now, if we follow her for another year, will she stay in remission or not? So I think we need to accumulate more data before we start recommending not to transplant these patients. So as of now, I would say, Bijal, whenever the patient is fit and transplant naive, whatever therapy the patient into remission, we still recommend transplant in this setting. But it is highly debatable. We've been in a lot of meetings, Bijal, and people, they have a different ideas. Patient treated in MRD setting, this is likely curative. You still need to do transplant. It's the challenge if you relapse after CAR T-cell therapy, one of those novel bispecific antibodies, options will be limited, especially as you kind of mentioned, if you relapse with CD19 negative disease, because patient already they get exposed to blinatumomab, and now you give them either one of the emerging bispecific or CD19 CAR T-cell therapy. So much pressure on CD19, and I worry about actually risk of relapse with CD19 negative disease, where options will be significantly limited.
Absolutely. I mean, now subQ blinatumomab moving front line, right? So we'll have the AUDEX trial that'll open hopefully the next month or so across the US and Europe. But that's going to be a big deal, right? You know, with the subQ blinatumomab, the PK that they're talking about achieving means that the patients who progress will likely be progressing without CD19. And I think that that's going to really change it. For all the discussion we're talking about. It's still a chemo backbone. I still don't know if it's the perfect solution. It's still lots of therapy, but it's still, I think the closest we have to the ECOG-1910 design, we're trying to advance, the subQ blinatumomab forward. But it, again, with that approach, we may really be under the wire here a little bit, right? I mean, we're going to have to find alternative approaches and ways of trying to get these patients back into remission. But I love what you said. I want to say unequivocally that I agree with you. Transplant for all comers with newly diagnosed ALL is not where we are anymore. I think that we have such effective therapies for first relapse that we need to think hard about who's getting transplant in the frontline setting. I'll still transplant the P53s and again, the mixed phenotypes and these others, but by and large, we really have to thoughtfully, step back from our ECOG 2993 experience and say, okay, well, maybe with CAR T, maybe with Surovatamig, maybe with MK-1045 and subQ blinatumomab, what we're really saying is transplant is relegated to first relapse. And, given the fact that these therapies work so well, the novel bispecifics, even in that post-CAR, post-blinatumomab setting, you also got to wonder, maybe what we're really saying is outside, again, those high-risk genotypes, maybe even for, second relapse. And I'm not saying I'm not willing to commit to that just yet, but I think that may be where we're realistically headed. And that's certainly where we are in other lymphoid neoplasms like large B-cell lymphoma and others. We're really waiting to third line plus because our agents just keep getting better and better. I really appreciate that. We didn't really talk a lot about CRS or ICANS with the different approaches. You mentioned a little bit with the Surovatamig that you're seeing low rates of CRS and ICANS and maybe even lower with MK-1045.
Yeah, I mean, with the MK-1045, I mean, what they have seen no ICANS at all, although they have seen maybe around 40+% all grade CRS, and maybe grade 3 was around 3%. Maybe subQ blina, we're seeing more ICANS, grade 3 and higher, but it's also reported as manageable with treatment. CAR T-cell therapy, I mean, it was more challenging with the older CAR T-cells because it can take longer time for the ICANS grade 3 and 4 to resolve. And again, we're getting better and better with the CRS management. And the truth, I mean, as you know, Bijal, with the ROCA real-world data, I mean, the majority of patients treated before CAR, they're treated in MRD setting, and that maybe explain why we're not seeing many grade 3 CRS, but ICANS at least with Brixacil remain high, grade 3, but it is manageable. And now we have obe-cel where we see actually less grade 3 ICANS and CRS. So I think we're getting better in managing CRS and ICANS, and we're having actually a newer CD19 immune therapy that produce less actually high-grade CRS and ICANS. So I think ICANS and CRS less a problem nowadays compared to before, and typically it happened early on. That usually beyond the first, second week, it's not something you keep seeing afterward. I mean, toxicity is important, no question, but since it is manageable, we're seeing less. I think the primary kind of focus should be efficacy. I think second will be convenience. I mean, what happened after the initial phase? You achieve remission, patient not going to transplant. I mean, how frequent they need to come to the clinic or to the hospital to receive treatment.
I wanted to ask what you thought about cytopenias and in particular infection, and we've seen that really stand out with CAR T-cell immunotherapy. And so, you hit the nail on the head, right? In terms of CRS and ICANS and kind of what what we've seen and how we've gotten better at picking the right patient, but also even in the right patient, managing those toxicities much more effectively when they do occur. But, and it's a big but, we're still stuck on the back end, right? It's about a 15%, overall mortality after non-relapse mortality after CAR T, almost half or more a reflection of infection with CAR T, and kind of speaking to hypogammaglobulinemia and all the pieces that come with that. And so I don't know if you had any thoughts, particularly now as we talk about maybe moving bispecifics earlier in that space, in terms of what we can expect in terms of keeping patients safe. Maybe it's something we also need to approach with the same, diligence may not be the best word, but, thinking about antibody levels and, prophylaxis with acyclovir or Bactrim or something along those lines.
Yeah, I would say cytopenia is more a problem, prolonged cytopenia, after CAR compared to bispecifics. At least from my experience with Cervatimig, although we have reported, as you're aware, prolonged thrombocytopenia, but I don't think it is purely related to the drug because, what happened, we're able to actually continue the drug with thrombocytopenia, and the patient recover the platelet while they're receiving the target dose of Cervatimig, and that wasn't very common. Well, we see it more common after obe-cel and Prixacel and Tisacel, that eventually actually many of the patients eventually recover their counts, but it can be prolonged, can last as 8 weeks, sometimes even longer, and you can see infections in that setting. My experience with the bispecific antibodies, I'm not sure if we're seeing more infection than what you expect for any salvage therapy. And they tend, the majority of patients, they tend to recover their counts at the time of end of the first cycle, and they tend not to drop the counts with continuing therapy. Now, hypogammaglobulinemia, I think it's always comes to a question with bispecific antibody, with CAR T-cell therapy, and there's a debate if it's needed, if you need to replace IVIG or not. But I tend to do. These patients, especially if they are heavily pretreated, advanced disease, they've been neutropenic for a long time. We try as much as possible to optimize their immune system to reduce the risk of infections. And as we move it to kind of frontline therapy, this patient will be kind of treatment naive initially. We may not encounter as many infections as in my CAR T-cell study. Although we saw some prolonged cytopenia, wasn't as much as what we have seen in the relapsed refractory setting. And I can share with you, infection wasn't a problem. I can't think of any patient who experienced infection. They have grade 1 CRS, but actually isolating bacterial infection, fungal infection, I can't think of any patient. So maybe as we move it to the frontline therapy, this will be less of concern.
Thank you, Drs. Aldoss and Shah, and many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Shaping the Future of ALL, Clinical Advances in Immune Engager Therapies and Patient-Centered Care, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.